is about iliac and SFA intervention of chronic total occlusion. So this is a 66-year-old gentleman known to have peripheral vascular disease. He's been having shortness of breath, severe leg pain, and numbness with exertion and at rest involving his legs. In 2009, he had unsuccessful attempt at intervention of the right SFA. In 2010, he underwent right fem-pop as well as right to left fem-fem bypass at a community hospital. A year later, he had bilateral aorto-biprofunda bypass at a university hospital. When he came to my clinic for the first time, he was examined, evaluated, and arterial duplex showed occluded fem-fem graft, bilateral SFA, were also occluded the vessels reconstituted at the level of the peroneal and the anterior tibial arteries. So I did a CTA of abdomen and runoff here. Good. So there's no aneurysm. This is the aorto-biprofunda bypass. You see here the native iliacs are totally occluded. There's nothing in the iliac system, common, external, internal. The right side reconstitutes at the level of the popliteal artery. The left side reconstitutes at the distal SFA. Runoff, below the right knee, there is like 2.5 vessel runoff there, and 1 to 1.5 left side. So this was discussed again with the patient, and options were discussed whether he wants to go for surgical evaluation, see what they can do. He absolutely refused. He was brought to the cath lab. I obtained a right radial arterial access, placed a 5/6 French slender sheath, advanced a multi-purpose diagnostic catheter over advantage wire. I had to use the pigtail catheter, try to deflect it away, and then exchange it out for multi-purpose. So I also obtained under ultrasound guidance, an anterior tibial arterial access. Initially placed a 4/5 French slender sheath, then advanced a glide wire advantage and an over-the-wire catheter. I believe it was Trailblazer at that time. So I tried to intervene from below, advance it all the way up to the common femoral. This is the Trailblazer, but nothing would pass beyond this point. The CTO, I ballooned it at that point and tried using a stiff glide catheter, trying to penetrate that gap in the common femoral without any success. I tried Pilot 200 and Confianza, no success. Command 0118, Astato, absolutely nothing. Gaia third actually did make some progress. I tried at some point also to intervene also from above, no success. So I used a Navicross and Gaia third, was able to make some progress here, then advanced the catheter. It actually deflected itself down, and at that point I was sure I'm in a true lumen. I injected here. I was in the internal iliac, then pulled it back and deflected back up, advanced Gaia third, all the way up to the aorta. I compared pressure and made sure that I was in the true lumen in the aorta, which was the case. After that, I advanced multiple balloons from below the pedal axis, then advanced a glide advantage in the multi-purpose guiding catheter all the way down to the popliteal artery. Then, at that time, I did not want the size of the vessel would not of the pedal artery would not accept a 7 French. Also, I was anxious that some perforation of the internal iliac might happen. At that time, I had just inflated only 4 millimeter balloons. So I had to go over a stiff wire using the radial arterial axis. I upgraded the system up for a 7 French 90 centimeter sheath, parked it as far as I could, and guided the deployment of 2 stents in the iliac system by injecting from below. So an 8059 OmniLink was deployed across the common femoral artery, then an 8080 self-expanding to cover distal to that with some overlap. This is angio after the stents were placed. Still, work was not finished across the distal SFA popliteal. So advancing stents from above they won't reach. So I upgraded the pedal axis to 5/6 slender sheath. Then I advanced, was able to deploy a 60150 pulsar and 6.560 Supera stents. Then these are the final pictures. We did some post-dilatation, and this is the final runoff. Great iliac system, no perforation. This is the stump of the previous surgery. SFA is wide open, stents very well expanded, and the following day we did ultrasound just to assure that we still had flow in the anterior tibial artery and make sure that we have at least biphasic flow. His symptoms in that leg improved. We brought him actually a few weeks later and intervened on the left side using the same technique.
Extremely interesting case. I'm tired just hearing about it. Usually, it's the other way around, right? We start with endovascular and you have surgery to, after we run out of options. And here you're back to trying to do something from an endovascular standpoint. And I think once we're in that point, kind of all our standard things go out the door. We're trying to get flow into the foot as best we can and to the extremity as best we can. Obviously, a lot of different decisions that you had to make during this case. And, I'm curious to see just what your plan was before you started and how that changed. And then your concern about, when I've attacked these kind of cases, I try to get back into that surgical graft. Because, now you've done this, now do you have a competing graft there? And you don't, if I take it out or if it goes down, is it going to compromise the other leg?
Mm-hmm.
And that's always been a concern of mine. So more of a comment, but a question. Before you started, you knew, this must have been a whole day affair, right?
Yeah.
And how you kind of talk to the patient, and then when you were there, how, these decisions, at any time did you say, okay, I got to stop and come back, or was this multiple stage procedures, or just one? And then the last thing is, did you ever think about getting into the graft? And, with the use of the outback and this and that, sometimes you can come up and then, okay, to me, once you get in the pelvis, the risks go up, right?
Mm-hmm,
because like
sure.
you said, you don't have a lot of backup, right?
Mm-hmm.
You got something in the wrist and you have something in the foot.
Right.
You don't have a lot of backup. So I try to stay away from the pelvis and, maybe an outback or something that I can get in and work with that infrainguinal stuff where I can at least control.
Right. Actually, before that CTA was done before we started the procedure in preparation for it, I sat with the radiologist trying to see whether there is any way to tell whether it would be a good idea actually to try to recanalize that graft or at least find anything. There is absolutely nothing, no indication that other than scar tissue, we couldn't find anything. The other thing that I had in mind is that once I start advancing wires, whether I'll shower thrombi everywhere down and then I create a problem that I'm sure I can't bail myself out of.
Excellent case again. Just a couple quick comments maybe.
Sure.
Radial versus brachial access here. Brachial would have saved you some trouble. Again, this is a high-risk case, so if it's not a high-risk case, then you can question saying brachial access have more complications. But here, brachial access could have allowed you to use even 8 French systems. Most brachial arteries can take 8 French. That's number one. And number two, again, along the same point, task D, long iliac occlusions. Some people do advocate placing stent grafts in the ICAS, which would have been a limitation for you because of your 7 French system. So your thoughts on those two?
Yeah, well, back to the surgical option, he was literally sick of seeing surgeons. He absolutely did not agree. He didn't want to see any local vascular surgeon, whether at our hospital or the other in the community. He did not want to go back to either Creighton or Omaha, UNMC. Surgery was definitely out for him. Yeah.
Okay, great case, very complex. Are you presenting our next case?
Yes.
Okay, great. Well, for the sake of time, why don't we move on to that next case?
Sure.
So the next case is going to be an iliac?
Yes.
Okay, iliac case, great.
And until they load up, brachial, I'm truly hesitant always to use it. When we sometimes also have to use any French system, let's say for the heart, a CTO or something, I might go sheathless, very carefully in the radial, trying not to really touch the brachial. The next presentation is about an intervention of chronic total occlusion of the iliac artery. This is a 54-year-old gentleman with severe peripheral vascular disease. This was found by actually a vascular surgeon longer than 10 years ago. He treated him with exercise and cilostazol. His primary care physician started him on baby aspirin in addition to cilostazol and statin and losartan or lisinopril. Patient came to me for a second opinion because for the last 2 to 3 years he's been having significant intermittent claudications upon walking less than 100 yards. He continues to smoke. He did not want to stop. We did the ABI at the office. The right was 0.5, left was 0.4. I did CTA, which showed bilateral occlusion of the external iliacs and the right common iliac with great runoff. Again, aorto bifem probably is a great option for him. He's young. He absolutely refused surgery. He refused even to see his own vascular surgeon. So brought him to the cath lab. I went radial approach, selected the left iliac artery with a long multi-purpose diagnostic catheter. When I saw this picture, I was very optimistic that actually things will go fast just because there is that pointed knob. Probably an 014 or 018 will just go through. It didn't happen. So I got a posterior tibial access under ultrasound guidance. Then continue to try to open it up from above. No success. I used an 035 Glide Advantage wire and Trailblazer catheter retrogradely. Didn't cross. I used initially a Pilot 200, then Confianza Pro 12. Along with Trailblazer, the wire did make it all the way up to the aorta, but not the catheter, so I exchanged it out for a Corsair. After that, I re-advanced Trailblazer. It did cross. I ballooned at that time the iliac. So this case actually was done before that one, before the one I just presented. At that time, I realized that there is something wrong. The shape of the bladder is not what it used to be. The patient at that time was still hemodynamically stable, but definitely there is something wrong. And at that time, this was done 2.5 years ago, I believe. At that time, I didn't have any 7 French system in the patient's body, so I had to move really fast. I didn't reverse heparin at that time because I have a pedal access. What I did is that because the size of, he's a big guy, because of the size of the posterior tibial was good, I exchanged the sheath out for a 6-7 French over the same wire, and then used a NATO 100 Viabam. It sealed it. Things went well after that, but angio, I wasn't happy of the internal iliac, and for such a young individual, I didn't want to leave it that way, so I exchanged the diagnostic catheter from the radial artery out for a long multi-purpose guide. I advanced pilot 50 wire into the left internal iliac, used a 4.0 coronary balloon and 6.0 Viatrec, inflated them across the ostium of the internal iliac. Then I did simultaneous kissing balloon from below and above, and there was dissection. Before I did that, there was some dissection right proximal to that Viabam. I kept these balloons up for 5 minutes. Still, it didn't, I wasn't happy. So I deployed a 9040 Absolute Pro right proximal to that stent, preserving the iliac. This is the final picture, great flow in the internal iliac, iliofemoral, and below the knee arteries. We didn't have to start him on pressors or resuscitate him. No blood transfusion. Yeah, so this actually taught me that once I start ballooning across the internal iliac, a 7 French has to be there. Yeah. And this is what I did with the following one.
Great case. Again, a lot of teaching points here, a lot of interest. First of all, I always say that when you're dealing with an occlusion in the iliac, you have to assume it's going to rupture. So everything is ready. You're assuming it's going to rupture. And again, was the patient under moderate sedation? Did the patient give you any indication that something could be going on here?
No. Nothing, absolutely nothing.
Usually, most of the times, mine, they tell me before I can figure it out.
It's actually interesting. Actually, there was absolutely no symptom. Blood pressure continued to be okay. It's interesting that I was explaining to the tech and the staff that, you know, one of the things that you always have to keep in mind, if any artery will give you some trouble in the peripherals beyond below the aorta, it would be the external iliac. And I said, one of the things to look for actually is the bladder. And I said, see, so the bladder is good. And it was like, it's not good. Wait a second, something is happening here.
That's very important. I think that's a great point. My question really has to do with crossing. You went through your crossing, multiple crossing wires and what have you. You know, traditionally, I still go 035 to try to cross these iliacs. And, you know, I think there was not much of a, you know, kind of stump inferiorly in that common femoral, but a lot of times I will puncture low of the common femoral and keep my distances short. Yeah. So I don't know if you considered that, but 035, keeping my distances short. And then if I get into subintimal spaces, I try to communicate in the middle. Mm-hmm. That way, at least I can communicate there. I think it's a safer area.
True. So what I usually do, I start with N035. I like advantage with a very thin knuckle. If it doesn't work, a stiff, straight-tipped glide wire, very carefully. I like not to go subintimal. I move to 018. Sometimes I just go to a Gaia third or Confianza, trying also my best not to go subintimal at any point. I'm sorry. This is, you know, I brought this patient also back and worked same technique. I opened the right side as well. So this is how he looks. Arterial duplex on both sides and ABI normalized.
Yeah, I have kind of similar sentiments to you, Tino, and I think when you do these external iliac occlusions, you really need to understand your lesion length and kind of establish your base of operations and make that lesion as short as possible. Mm-hmm. So I guess I don't necessarily disagree with your use of pedal axis, if nothing else, to take that retrograde angiogram with an antegrade angiogram and really understand the lesion. And I suspect at that point you could have potentially gotten ultrasound-guided proximal SFA or distal common femoral and still had a little bit of running room with a 7 French sheath to have bailout options. And I think that's a really important lesson we all need to be aware of when we're using or doing procedures on this segment.
True, and for any pedal access, I like to keep ACT at least like 270 to 300 or 320 all the time. And then we use our band, and you know, unlike radial, we were real light on pressure on our band across the tibial axis.
Just one thing that I think might be a good option nowadays is the Terumo R2P system with a 6/7 slender, 119 character that one Iliac would give you.
True.
Length is still an issue, but
These cases were done in 2017.
Yeah.
We didn't have, there weren't these long sheets at that time.
Well, I think we've learned, I've always tried to go retrograde first, but I think we learned that from, you know, there's definitely advantage of being antegrade,
Yep.
whether you're going up and over or from the wrist, at least having a catheter, at least having something there that you can have some control, I think is helpful. The last point is anticoagulation. I usually do not anticoagulate when I'm working in the iliacs because of this reason. I mean, usually there's good flow. You know, once I get across half my channel, then I'll go ahead and anticoagulate.
Mhm.
But again, it's one area that I'm usually aggressive, except for here. So.
We have one quick question in the back.
Unfortunately, a scenario we often see is a stump right at the aorta without a beak, no hypogastric. In this case, you're not hypogastric and a beak. If you have a stump at the aorta, does your strategy change at all?
Well, the right side did have a stump at the aorta. Right.
Same strategy?
Yeah. So I used a glide. Actually, that one I was able to open it anterogradely, not retrogradely. I just had a retrograde access to guide my intervention. So after I crossed, I exchanged it for a 7 French sheath because the stents will not fit the 6 French guides, or otherwise you need 8 French guides, which will be a problem.
And again, we talked about covered stents for these, class D type lesions, C and D lesions. But when you're dealing with that hypogastric, and that patient, that hypogastric was really important, right? The right iliac was occluded.
Yep.
That was really important. And sometimes that's the trick, right? You almost have to use some kind of hybrid. You want to use covered, and then when you get into a rupture situation, you're like, okay, now I'm stuck, right? I may have to sacrifice that hypogastric if I can't control the bleeding. So those are a lot of decisions you have to make.
True. We paid extra attention actually not to lose that one and cover where it ruptured. DSA, one of the DSA pictures showed where exactly the rupture was, which is like most of the patients, it's that point where it is.
All right, thank you very much.
Sure, thank you.